دكتورة معلش ما في صوت.
اوكي، ما كان في صوت طول الوقت ها؟
أيوة دحين في بس.
طيب اوكي خلاص نبدأ بس بسرعة. Okay, so we will start by localization, and before going through the steps and how to localize, which is the first important step in approaching any neurological complaint, we need to understand some few important points. The first thing is the nervous system. As we know, the nervous system is divided into central nervous system and peripheral nervous system. The central nervous system is mainly composed of the brain and the spinal cord, while the peripheral nervous system has the nerves, neuromuscular junctions, and muscles. And then you can see here in this slide, just a picture that's showing some illustration. So you can see that we have the brain that have the cortex. The cortex is the most outer part of the brain, and it has like the neurons, and then we have the subcortical area. Subcortical area is the area underneath the cortex, and it's mainly composed of the white matter or the tracts and the axons of the neuron. And of course, we have the deep gray matter that have the basal ganglia, the thalamus, and the other structure. But mainly when I say cortical, I'm referring to this outer layer, which is rich in neurons, okay? So it has all the neurons and it controls the higher function of the brain. So it's responsible about all the cognitive function, about the speech, about like the attention to the surrounding and all of these things. And then we have the subcortical area, which have the tracts like the corticospinal tract, the sensory tract like the spinothalamic tracts and other structures. And then from the cortex to the subcortical area, we go to the brainstem. The brainstem, as you know, is composed from the midbrain, bones, and then medulla, where the tract goes, and you have the cranial nerve nuclei. And all of this is part of the central nervous system. And then the last part of the central nervous system is the spinal cord. This is a cross-section of the spinal cord, and you can see that we have here also the gray matter and we have the white matter. It's slightly opposite to the brain, where you have the gray matter or the neuron in the inside, and the outer part is the white matter. The gray matter here has an important structure, which is the anterior horn cell. From the anterior horn cell, we will have a nerve root that join the sensory nerve root and form the peripheral nervous system, or the peripheral nerve, what we call it root and then nerve. It will move until the muscle. We have the neuromuscular junction, and then we have the muscle. So starting from the anterior horn cell and down is the lower motor neuron. Above the anterior horn cell, okay, or the motor nuclei, is the spinal cord, the brainstem, and the brain, which is the upper motor neuron. So this is a very basic but important point that everybody should keep in mind. And why we say this? This is important because when I do my neurological examination, I will look for sign and I see this is with upper motor neuron and this is with lower motor neuron. So for example, if you did neurology before, you will know that the upper motor neuron, you will find weakness, okay, which is the same. This is the main complaint, the weakness, but you will not see any atrophy if the lesion is in the upper motor neuron, which I mean in the brain or the spinal cord, but you will have some lesions and some atrophy when you have lesions in the lower motor neuron. And we mean by atrophy early on. With upper motor neurons, sometimes you have atrophy if there's a long-standing weakness and paralysis and the patient is not using the muscle, then we'll have an atrophy that's called disuse atrophy or misuse atrophy, which is atrophy because they are not using the muscle. But in lower motor neuron, you will see atrophy from the beginning. And then we look to the fasciculation, which is an abnormal muscle twitch. It's very common with lower motor neuron lesion, and we don't see it in upper motor neuron lesion. Reflexes are exaggerated or hyperreflexia in upper motor neuron lesion, while it's absent or decreased in lower motor neuron lesion. And we assess the tone. We'll see how increased tone or spasticity with the upper motor neuron lesion and decreased tone in the lower motor neuron lesion. So these are the things that I look in the examination, and it will help me more to localize where is the pathology. Okay, and then another important term that we hear a lot, we hear sometimes we say, for example, hemiparesis, or we say hemiplegia, paraparesis or paraplegia, monoparesis or monoplegia, and all of these terms. So what's the difference between paresis and plegia? Usually the paresis is just weakness or partial paralysis. So there is some power, but it's weak. If I say plegia, I mean it's zero power. There's no movement at all. So this is like the difference between paresis or paresis and plegia. And then we can divide the types of the paresis and plegia to hemi. Hemi usually it will involve one side, so it will involve the face, upper limb, and lower limb in one side. We have para plegia or paraparesis when both lower limb are involved. We have mono when one limb, either one limb in the upper limb or the lower limb is involved. We have quadriplegia or quadriparesis when you have the four or like the upper limbs and the lower limb both are involved, okay? And this is called quadriplegia. And to differentiate this from generalized weakness, sometimes I have patients who have weakness in the forelimb, but he has also weakness in the face and the cranial nerve. So I will not say this is quadriparesis or quadriplegia. No, I will say this is generalized weakness because everything is weak. But if the face is spared and he have weakness in the forelimb, it will be called quadriparesis or quadriplegia. Sometimes we use the term diplegia. Diplegia when I have weakness in both sides of the face. For example, I have facial weakness right and left, so I'll call it facial diplegia. I have weakness in both upper limbs, so I will say that the patient have both upper limbs, so diplegia when both upper limb is affected. But if it's both lower limb is affected, we'll call it paraplegia. So this is usually how we localize these or how we describe the uh, pattern of weakness. And it's very important because when you want to localize, you have to describe the pattern of the weakness. Certain pattern fit certain anatomical area. Another important information that you need to keep in mind also is do you see the slide or it disappeared? Okay, yeah, yeah. So usually, we have what is called the homunculus, or the homunculus. You know, this is the man that have his face upside down and the leg inside. So this is just what is the topographical distribution of our body part. You can see that we have the legs here in the medial part, or we call it the parasagittal area. So inside here, the sagittal area, we have the representation of the leg. The hand and the face take a larger part from the lateral surface or the outer surface of the brain. So you can see the legs take a small part. The arms or the hand, because the function is more complicated, will take a slightly larger anatomical part, but the face, the tongue, because it have a very delicate and specific complex movement, so they take a very large surface area of the outer part of the brain. So this will also help you in the localization. So if the lesion is the inner area or the medial area, the legs will be affected more. If the lesion is in the outer or the lateral area, the face and the upper limb will be affected more. Another thing is the sulcus. So this is the central sulcus, which is the largest and the deep sulcus in the brain. It divides or separates the frontal from the parietal lobe. And you can see this is the pre-central gyri. Okay, so it's in front of the central sulcus and it has the motor control. And then the both central gyrus, which is the first like gyri in the parietal lobe, is behind the central sulcus. It has the sensory control. So this is very important to see. If the lesion usually in the frontal, motor is affected more. If the lesion in the parietal, the sensory is going to be affected more. So Keeping all of these information in mind, okay, we usually approach the patient, take the history. We will discuss in the coming slide what are the important history points that we're going to ask, and usually do our neurological examination that's divided to higher cortical function. So when I do higher cortical function, I'm assessing the cortex. I do the cranial nerve, okay, usually I'm assessing more the brainstem, cerebellar for the cerebellum, motor and sensory, it will assess different neuroaxes starting from the cortex down to the muscle. Okay, so usually when I have a weakness, it could be a lesion anywhere in the neuroaxis. If the lesion is in the motor cortex, subcortical area, or the spinal cord, it will give me an upper motor neuron lesion. If it's in the lower motor neuron, anywhere from the anterior horn cell, peripheral nerve, neuromuscular junction, and the muscle, it will give me a lower motor neuron picture. So I have to identify what's the pattern of the weakness, and this pattern fit which area in the neuroaxis, and then I see this area, for example, the spinal cord, okay, my localization in the spinal cord. I start to think what are the diseases that can happen in the spinal cord, and then I look to what investigation I have to do to look for the spinal cord, and then I can reach my diagnosis by doing this. So starting by the first possible localization, we have the cortex. The cortex is very big and involve all the brain lobes, okay? But usually, in general, if the cortex is affected, I should see higher function affection. Higher function, mainly I can see aphasia. So the patient will have some Broca or Wernicke's aphasia, unable to speak, unable to understand, okay? So this is a higher function. I can see the patients having some apraxia. Apraxia is inability to perform the task. It's mean يعني المريض بالعربي هنسميها خرق أو عتة. المريض ما عنده weakness, okay? الباور is okay, but he is unable to perform the task. أعطيه مثلا فرشة أسنان, he doesn't know how to brush his teeth because he has apraxia. So this is a higher motor function, which means the cortex is affected, or we can have agnosia. The agnosia also, it's an ability to recognize the object. The patient is not blind, but when he sees things, he does not recognize them. It could be agnosia for shapes, it could be for objects, it could be for pictures, okay? So, for example, I will show his finger, for example, because he has agnosia, he does not recognize that this finger is part of his body, okay? Or I can show him a picture that have faces and he's unable to identify the faces and who are these person in the picture. So this is also a higher cortical function. So if I examine the patient and I have these findings, so the higher cortical function is impaired, or sometimes if I have a very large lesion in the cortex, the patient will present by decreased level of consciousness, coma, seizures, severe confusion, encephalopathy. So all of these is mean that the cortex is involved. So we will have the higher cortical function, plus I will have a contralateral weakness or sensory loss. Okay, it depends. For example, if the frontal area is involved, he will have a contralateral weakness. If the parietal area is involved, so he will have a contralateral sensory change. And the other thing that is important, remember when we say that we have the homunculus, so when I have weakness or sensory change, it should not be even. Sometimes I'll have weakness more in the face and the upper limb if the outer area is involved. And that's what happened with, for example, middle cerebral artery stroke. If the medial area is involved, I will have weakness or sensory change more on the contralateral leg. And this can happen with anterior cerebral artery syndrome. If both are affected, usually, yeah, I will have weakness everywhere. But usually, sometimes I'll just have weakness, for example, in a small, like I have a lesion in a very small area that, for example, control the hand function. Okay, so the patient will present with isolated hand weakness and upper motor neuron finding. Okay, maybe he will have some cortical function or not, but this all localized to the cortical area. Okay. So if I have a patient who have a cortical lesion and I perform my neurological examination, I will find the following findings. So the patient can have aphasia, the patient can have apraxia, can have agnosia. Aphasia, usually if it's in the dominant hemisphere or in the left side. Apraxia and agnosia happens more with the non-dominant hemisphere. If I examine the cranial nerve, they will be normal. Cerebellar function, it will be normal. I will find a motor weakness, okay, and it depends which area of the homunculus it hits, okay, so maybe the upper limb is affected more than the lower limb or vice versa. I can have a sensory change if it's hit the sensory area or the sensory homunculus. Upper motor neuron finding, so hyperreflexia. I can find pathological reflexes like Babinski sign, for example, or positive or upgoing toe. So that's what happens when we have a lesion in the cortex. What are the classic example of cortical lesion? A stroke can cause cortical lesion, demyelination, tumor. So if I have a patient who present with finding suggestive of cortical lesion, I will look to the time onset. If it's something sudden onset, then it goes more with stroke. If it's something that happened over a few days, it will be more with demyelination. If it's something that have been going for a longer time, I would think of a slower process like tumor or abscess. And usually the diagnostic tool that I will use to do investigation for a possible cortical lesion would be a brain image, either a CT or MRI brain. Okay. So this is the first step in localization. Moving to the second level, it will be the subcortical area. The subcortical area, it have the white matter. So it have all the axons from the cortex gathering in a very small fibers, like the corticospinal tract, the spinothalamic tract. So usually when I have a lesion in the cortex, I will have something that's called dense hemiplegia or dense sensory loss, which means that the upper limb and the lower limb and the face are all equally affected opposite to the cortex. The cortex زي ما قلنا يختلف حسب الاريا اللي هي involved. ممكن الأبر limb affected أكثر من اللور limb أو العكس. بس لما يكون عندي lesion في subcortical area, usually there is equal involvement, okay, face والarm والleg. ممكن يكون weakness if it's hit the corticospinal tract، أو ممكن يكون sensory abnormality if it hit the spinothalamic tract. هل هيكون في higher function affection? Do you think that the higher function will be affected in the subcortical area? ممكن يكون في aphasia ولا agnosia?
No,
Yes. So there will be
no.
no higher cortical function effects because it's just purely tract, okay? افحص المريض زي ما قلنا هلاقي normal cortical function. cranial nerve nuclei هتكون كلها normal، بس ممكن يكون في visual field cut لانه ال visual fiber goes in the subcortical area. if it's hit this area ممكن الاقي في visual field cut. cerebellar is normal طبعا لانها في subcortical area part of the central nervous system, so we'll have upper motor neuron with hyperreflexia, upgoing plantar. وزي ما قلنا الموتور ويكنس هيكون equal face arm and leg كلها affected زي بعض. لو كانت sensory نفس الشيء هتكون كلها affected equally، فعشان كده نسميها dense hemiplegia or dense hemisensory loss. فلما أي مريض أفحص وألاقي الويكنس equally distributed أبدأ أفكر إنه this could be subcortical especially لو كانت upper motor neuron وما في higher function affection. طيب what are the classic examples that can cause subcortical lesion؟ أكثر شيء that present with subcortical lesion is the lacunar stroke. اللاكونز okay هي اللي هي small penetrating vessels okay that supply the deep subcortical area، فكلها small vessels usually size حقتها between 10 to 15 millimeters. فإذا صار في atherosclerosis and changes and occlusion of these blood vessel أكثر شيء يحصل مع البيشنت اللي هم الهايبرتنسيف they will have these small lacunes okay أو نسميها lacunar stroke. Sometimes if it's hit a silent area ممكن المريض ما يكون عنده أي symptom but I find them in the brain image. But if it's hit like the fibers of the corticospinal or the sensory, the patient will present with the symptoms that we mentioned, and I do the brain image and I can find these small lesions. So small lesion like this sometimes will produce a significant deficit, especially if it's hit the corticospinal tract. واضح? So this is an example of subcortical lesion. Okay, moving from the subcortical area, we'll go to the brainstem. So the brainstem, it's basically like a station that collects all the tract that's going from the brain to the body on the tract that ascending from the body to the brain. ففيها مثلا الcorticospinal tract، فيها spinothalamic tract، فيها الdorsal column tract that convert or like convey temperature والproprioception. ففيها كل tracts plus إنه it has the cranial nerve nuclei inside the brain stem. So if I have a lesion in the brain stem يعني كده biologic إنه هيكون في affection in the cranial nerve nuclei and في affection on these long tracts، وممكن يكون في weakness زي ما قلنا contralateral hemiparesis or contralateral sensory loss حسب التراكس اللي affected. But the characteristic features that you have always to keep in mind when you are approaching patients who have brainstem lesion is a term that's called cross hemiplegia. Okay, so the patient will have something called cross hemiplegia, which means there is a weakness in the face in one side, okay, and contralateral weakness in the upper limb and lower limb of the body. طيب, why we have this? اللي بيصير بالضبط إنه صار في lesion في الbrainstem. Okay, so the cranial nerve nuclei اللي موجودة في هذا مثلا في الليفت area of the brainstem هيكون عندي left cranial nerve weakness، سواء مثلا عندي left facial، عندي مثلا affection للextraocular muscle، للabducent، الميد brain، فهيكون في عندي affection في الcranial nerve في الفيس in this area. التراس لأنها هتعمل crossing و decussation في المظلة فهتعطيني contralateral weakness. For any patient that you examine and you find cranial nerve nuclei in one side affected and the contralateral side there is upper and lower limb loss of sensation, or there is like weakness with upper motor neuron side, always think that this is most likely not a cortical or subcortical area. It would be a brain stem affection. طبعا الcranial nerve nuclei اللي get affected usually هيكون مثلا extraocular muscle، فهيكون البيشنت عنده diplopia، ممكن البيشنت يكون عنده disequilibrium لو ال vestibular nerve nuclei get affected، البيشنت ممكن يكون عنده dysphagia لو كان اللي هي الvagus والglosopharyngeal nerve is affected. Okay, so usually think that the patient will have dysphagia, dysarthria, disequilibrium, and diplopia. 4Ds. So the patient, if have any of these 4Ds, complain with contralateral long tract signs, اللي هي weakness and sensory loss in the other side. Always, this is a brainstem lesion. Common cause could be stroke. It could be demyelination like multiple sclerosis, it could be infection, tumor, stroke ممكن تكون hemorrhagic or ischemic, okay, or vascular malformation. So basically any like pathology can hit the brainstem. اللي يساعدنا على differential diagnosis, the history and the onset of the patients. تمام? Okay, so this is very important to keep in mind the crossed hemiplegia when assessing a patient who present with different location of cranial nerve and weakness. فزي ما قلنا examine the patient, higher function is normal, cranial nerve could be affected, all of them or some of them depending on the area that it's affected في brainstem. هلاقي في ممكن عندي hemiparesis with upper motor neuron side, hemisensory loss, okay, or hemidysesthesia لأنه حيكون في sensory loss وحيكون في hyperesthesia, aggravated sensory changes, deep tender reflexes هتكون exaggerated لأنها upper motor neuron side، وهيكون عندي pathological reflexes. تمام؟ And we mentioned the classic example of brainstem lesion. Okay? طيب, imagine that you have a patient who present with unilateral weakness. Okay, it seems like a hemiparesis or hemiplegia, but it's sparing the face. Okay, so the patients have weakness involving an upper limb and the lower limb in one side, but sparing the face. فهذا هيخلي cortex, subcortical, and brainstem كلها is out. Okay, so I would think that this most likely is having a spinal cord lesion. طبعا because the upper limb and the lower limb is affected, it could be most likely something in the cervical spinal cord. طيب ليش صارت in one side؟ لأنه spinal cord ممكن يكون في lesion causing complete transection, so the patient will present with quadriparesis or quadriplegia. وأحيانا the lesion it will not affect all the spinal cord. Okay, فهيكون في just hemisection or hemilesion، فهيكون عندي affection only in one side. طيب إيش الباثولوجي اللي ممكن تيجي في الspinal cord؟ MS is very common. Okay. ممكن trauma. Okay. سواء fracture or disc prolapse, compression, infection, بعض metabolic disease زي vitamin B12 deficiency can affect the spinal cord. Okay. So just like كده review quickly the anatomy of the spinal cord. We know that start from the medulla and then the cervical area, thoracic. وبعدين في الادult the spinal cord usually end at the level of L1 and L2. So below L2 there is no spinal cord. كلها هتكون the fibers اللي نسميها الcoda equina, then will give us the roots for the lower limb. So the spinal cord stop at the level of L1. That's why when we do a lumbar puncture, usually you go between L4, L5 or L5, S1, and we assure the patient that we are not hitting the spinal cord. So don't think that you're going to have paraplegia or paraparesis. This is one thing. The other thing, this has also helped me in localization. فأنا عندي lesion في cervical area ممكن يعطيني quadri plegia or quadriparesis affecting both the upper limb والlower limb. Okay. ممكن تكون complete if it's complete transection أو ممكن تكون hemi. If the lesion is below the cervical area, so it will be sparing the upper limb. It will affect only the trunk and the lower limb. Okay. And then the last level of the spinal cord that can cause lesion, it will be something opposite to L1 and L2 that can cause paraplegia. And of course, if I examine the patient, I'll find an upper motor neuron sign, I'll find a bowel and bladder involvement. But there is an important point that always we look for. احنا تكلمنا كثير عن الموتور assessment والموتور exam, بس in assessing the spinal cord هيكون الsensory examination a very important role in localizing the lesion. So remember that we have the dermatomes. The dermatomes هي area from the skin that's supplied by a certain nerve roots. Okay. So for example, I have a nerve root, okay, that's coming from C3. It will supply this area just above the shoulder. C4 here, for example, C5. Okay. بعدين عندنا important landmark, for example, across the nipple, this is T4. مثلا T4, you should know that this is opposite to the level of the nipple. For example, T10, okay, it's opposite to the umbilicus. As we mentioned, that's the spinal cord end at L2. So usually if there is a lesion in the spinal cord, the sensory change will be up to here to L2, but any sensory changes below this area, okay, it's mean that the lesion is not in the spinal cord, it will be in the peripheral nerve. For example, I have a patient who presented with weakness and I then start to do the examination. So all the sensation is lost up to the level of T10. Then after T10, he starts to feel. That means that the patient most likely, if he have weakness and upper motor neuron sign, that he have a lesion in the spinal cord opposite to the T10 or the thoracic vertebrae number 10. فهذه هي فائدة الدرماتوم في اللوكاليزيشن. Imagine that I have a patient who have bilateral lower limb weakness. I examine the patient. There's decreased sensation up to the knee. Okay, up to the knee. يعني this is dermatome L3. As we say that spinal cord end up here, high here, up in L2. So if the patient have sensory changes or sensory level up to L3, فمعناته the lesion is not in the spinal cord. It will be in the roots below the spinal cord. Okay, so if I have a patient who presented with possible spinal cord lesion or like quadriparesis or paraplegia, I examine the patient. I look for the sensory level. If there's a sensory level at L2 or above, فهذا okay will prove that this is most likely spinal cord lesion. In addition to finding upper motor neuron sign, bowel and bladder involvement. And we mentioned the classic example اللي ممكن تحصل. ممكن يكون pathologic spinal cord زي مثلا multiple sclerosis, tumor هيحصل فيه infection, infarction, metabolic أو ممكن يكون something compression like fracture or disc prolapse. Okay. طيب, moving from the spinal cord كده we finish all the central nervous system or the upper motor neuron. Okay. نبدأ إيش ننزل تحت على peripheral nervous system. Okay. peripheral nervous system localization is يعني less complicated honestly. نبدأ أول حاجة زي ما قلنا عندنا anterior horn cell. anterior horn cell اللي هي عبارة عن الموتور نيوكلياي اللي موجودة في spinal cord. From the anterior horn cell we have the nerve root. The nerve root will form the peripheral nerve, okay, which joins the sensory ganglia, بس هي sensory outside the spinal cord يسموها dorsal root or the posterior root ganglion. They will form the nerve roots and then they will form peripheral nerve, neuromuscular, and muscle. If I have a lesion involving the anterior horn cell, which is like it's not very common, okay, لكن anterior horn cell حتعطيني كده unique picture, okay, حتعطيني something called, okay, motor symptoms. ما حيكون في sensory symptoms but هتكون mixed فيها بعض upper motor neuron و lower motor neuron findings. So if you see a patient who have, for example, weakness with atrophy, fasciculation, which is lower motor neuron, but I examine and he have hyperreflexia, there's no sensory changes, okay, maybe there is, okay, some atrophy زي ما قلنا, fasciculation, always think that could be an anterior horn cell. The classic example, it's the polio والاميوتروفيك lateral sclerosis اللي يسموه ALS or motor neuron disease. If you remember that there was a challenge that called the ice bucket challenge اللي كانوا يحطوا bucket فيه ice ويرموه عليهم to support patient with ALS or amyotrophic lateral sclerosis. Some people confuse between ALS and MS. They are totally different pathology. MS usually localized to the brain, spinal cord, so it's a central nervous system disease. Amyotrophic lateral sclerosis, it's a neurodegenerative disease affecting the anterior horn cell. Usually it's slowly progressive and fatal disease, but alhamdulillah, it's a rare disease. Okay, moving from the anterior horn cell, we go to the nerve roots. But the roots, usually, because it has motor and sensory component, the patient will have pain. So pain is a very classic feature of radiculopathy. So if the patient presents with pain and weakness, okay, always think that could be a root problem or radiculopathy. When you examine the patient, you can see sensory changes in certain dermatomes, okay, and because it is a lower motor neuron, so you'll see hypotonia, wasting, hyperreflexia, all the lower motor neuron sign. One of the classic example of root or radiculopathy problem, it's when we have a disc, okay, and it's causing disc bulge or disc prolapse, compressing the nerve root, and will give you like monoparesis or monoplegia either in the upper limb or the lower limb, and it will give you radiculopathy. Another example of radiculopathy, but it's a polyradiculopathy, يعني radiculopathy symmetric and everywhere, is GBS or Glanberry syndrome, where there is involvement of the roots and inflammation everywhere. They also present with weakness, some pain, and ascending paralysis with lower motor neuron sign. Okay, so this is an example of radiculopathy or root problem. As we say, when examine the patient, أكيد the higher function, the cranial nerve, cerebellum is normal. The motor then will be weakness. Sometimes it's asymmetrical depending on the root اللي هي involved. There will be some sensory changes and lower motor neuron sign. Plantar will be downgoing. فهذا يساعدني أفرق لو مريض عندي GBS or MS or GBS for example, or having spinal cord lesion. So the GBS will have, okay, paraplegia or paraparesis, but you will have hypotonia, hyporeflexia, and there's no sensory level. While the patient who have paraparesis or paraplegia but having spasticity, hypertonia, hyperreflexia, and sensory level, this is a patient who have a spinal cord lesion. So both patients have the same pattern of weakness of bilateral lower limb, but the exam helped me to differentiate between the two and to localize the lesion accurately. فأنا شكيت إنه المريض this is going with features of spinal cord. I will image the spinal cord. The patient features going more with polyradiculopathy or Glanberry syndrome. I will do more investigation for the peripheral nerve. ممكن أسوي nerve conduction study. I will do a CSF study looking for inflammation. But that's why always it's very important to understand localization and know how to do your neuro exam to reach this localization. Moving from this to the peripheral nerve, we can have weakness, okay, in the peripheral nerve. Peripheral nerve ممكن تكون mononeuropathy, مثلا median nerve causing carpal tunnel syndrome, peroneal nerve مثلا causing foot drop, radial nerve causing wrist drop, or it could be polyneuropathy. Polyneuropathy يعني involvement of all the nerves. The classic example اللي عليها اللي هو diabetes. فنسى diabetic polyneuropathy is very common. You must have seen a patient with diabetic polyneuropathy. Okay, so usually when the patient having peripheral nerve disease, they will present with something that we call distal weakness. So pay attention to this point because we have distal weakness and we have proximal weakness. Distal weakness fits more with peripheral neuropathy. Proximal weakness fits more with myopathy. Both are lower motor neuron weakness, but distal weakness, you will have a weak hand grip. So the patient, for example, will not able to open the water bottles, open the doorknob, do the buttoning. Any fine movement with the hand will be difficult. Okay. The feet also, maybe she have difficulty wearing shoes, tripping. They will see a foot drop. Okay, and this is a distal weakness. So distal weakness always point to peripheral neuropathy. When we do the sensory examination, we can see something that's called a glove and sock distribution, as the patient is wearing a glove and a socks. Usually start by the feet because it's length dependent, so the longer nerve get affected first and then the upper limb is affected. But if I examine a patient with peripheral nerve lesion, as we see, all the upper motor neuron or the higher function will be intact, cranial nerve, cerebellum, motor is distal more predominant. You can see sensory changes and a glove and stock distribution depending on the severity. If it's early, maybe just the tip of the toes is affected. If it's very advanced, you may have sensory loss up to the knee, for example. Deep tendon reflexes are hypo, and there's no upgoing plantar or other pathological reflexes. Okay, moving from the peripheral nerve to the neuromuscular junction. Neuromuscular junction, I find the student always knowing it very well, understanding it very well, because I think the pathophysiology is clear. We have the nerve joining the muscle at the neuromuscular junction. Usually, the classic example of this disease is myasthenia gravis. We have another disease that's called Lambert-Eaton syndrome. It's something that mimics myasthenia gravis, but it's more common in patients who have malignancy like the lung cancer. The hallmark of neuromuscular junction is fatigability, because initially the neuromuscular junction have a lot of acetylcholine and can release and stimulate the nerve. With exhaustion, it will get fatigue easily. So maybe you examine, it's normal. You exhaust the patient, and then we have fatigable weakness. The patient also complained from weakness at the end of the day, change in the voice, diplopia, droopy eyelid, difficulty climbing the stair or standing, that it's fluctuating. Usually there's no sensory symptom because there's no sensory nerve. It's just like the nerve ending and the muscle, so sensation is intact. When I examine the patient, it could be generalized weakness, so it could affect the face, upper limb, and lower limb, and the hallmark, as we mentioned, is fatigable weakness. Okay, so when I examine the patient, as we say, normal higher function, fatigable weakness, for example, fatigable ptosis, maybe there's no ptosis initially. I ask the patient to look up, okay, for 10 seconds, then I start to see some ptosis, okay. There may be facial weakness, weakness in the jaw closure, cerebellar is of course intact, the motor exam is fatigable, so it's maybe initially normal, but if I ask the patient to exercise, then I examine again, I will find that there's worse weakness. Sensation is normal, so this is very important. Deep tendon reflex is also normal, and there's no pathological reflexes like Babinski signs. Okay. Finally, we reach the last part of the neuroaxis, which is the muscle. So the muscle, as we said, it's a proximal weakness opposite to the distal weakness in the peripheral nerve. So the muscle will have weakness in the proximal arm and the leg. Proximal weakness, يعني weakness في shoulder والarm, weakness في thigh. So usually the patient will have symmetrical weakness. He will have difficulty in performing tasks that require raising the arm above the head level. For example, when brushing or combing the hair, when washing the hair, women's or lady wearing their scarf, it will be difficult. Reaching objects in a higher shelf will be difficult because of the proximal weakness. In the lower limb, they will have difficulty, for example, standing from a sitting position because of the thigh, they are weak, difficulty climbing or ascending the stair. And again, because it's a muscle disease, there's no nerve involvement, sensation is normal, but they can complain sometimes from cramps and aching. So don't mix cramps and aching pain with abnormal sensation, because when you do sensory exam, it will be totally normal. There's a lot of causes for muscle disease. The classic example is inflammatory myopathy, like dermatomyositis, polymyositis. It could be drug induced, for example, with a statin medication that lower the cholesterol level could induce myopathy, or it could be an inherited muscle disease like Duchenne muscular dystrophy. So when I examine the patient, I will find everything is normal except the proximal weakness. If it's sometimes I can find atrophy, fasciculation, sensation is normal. Deep tendon reflex usually is preserved, okay, until very late in the disease, but usually it is preserved, okay, and there's no pathological reflexes. Reaching this, we finish our localization. It's not the end, it's the beginning to understand and be able to approach neurological disease as you are studying or practicing neurology. By that, my talk is finished, and thank you for everyone. And if you have any questions, feel free to ask.
يعطيك العافية دكتورة، مرة مشكورة.
اوكي، يعطيكم العافية وبالتوفيق إن شاء الله. والمحاضرة إن شاء الله هتكون مسجلة. It will be posted in the club for the student in King Abdulaziz. It will be also posted for them. Okay. بالتوفيق.